everybody. We are very excited that you'll join us in this first webinar in the series Masterclasses for Ukraine. Wendy and I will be the host during these webinars, and we will briefly introduce ourselves and then continue with our first guest, Valentina and Tim. Wendy, would you start with introducing yourself?
Yes, hello, I'm Wendy Weitz. I'm a clinical psychologist and working as a board member at the Foundation World Psychologist, Wereldpsychologen. That's a foundation who provides online psychological support for refugees and in this moment for Ukrainian people. Our network is about nearly 600 psychologists who join us, and right now every day they get some email from Ukrainian people who need some mental health support, and then we make a match. And the psychologists and the people from Ukraine start to have online as many and how often they want to see each other. And also we have a lot of youth people or children, and then we try to see if we can find a psychologist who live nearby when the people from Ukraine are in the Netherlands, and then we try to provide walking sessions, for example. So it is based on all voluntarily. So the psychologist is voluntarily, and our organization, and we're really happy that we now welcome also all the psychologists who join World Psychologists in this project.
Yeah. And well, my name is Esther Hayema. I'm a psychotherapist and I am volunteering for Psych Global. And that was founded in order to facilitate access to professional mental health care for those people who are with cultural or language barriers. And we are building an international platform of very experienced and motivated professionals that can be hired by local care institutions. So we're gonna connect them with each other so they are able to work in the Netherlands, for example. Wendy, will you tell something about this initiative, this webinar?
Yeah, it's a really nice collaboration between World Psychologists and Psych Global and Psyflix, and also Friends of Puluki. That's a group of people in Holland and in Ukraine who work together for many years. And there was a question about EMDR training. A lot of Ukraine psychologists who were in Ukraine right now ask for them. So that's the reason that we set up EMDR training. And beside the EMDR training, there was also the question for some webinars, some educational. So that's a combination. That's the reason that we had these 6 webinar series for Ukraine psychologists who participate in the EMDR training. So for them, very welcome. And this webinar is also for all the psychologists who from Ukraine who also join our network in World Psychologists, and also the psychologists who were joining Psych Global. And that's where we thought, well, this is very interesting for all of psychologists in the Netherlands, but also in Ukraine or where they are in Europe.
Yeah. And so today we're going to start with mental health care a bit more in general. When do you have to intervene as a psychologist, and when do you have to focus on other aspects? And next week we will have a Dutch psychotherapist and a Ukrainian psychotherapist who are working together, and they're gonna tell us more about this collaboration and about the differences for a Ukrainian psychologist and a Dutch psychologist in working style. And the week after we gonna talk about sexual trauma and abuse. The week after it's gonna be about youth. And then the 5th webinar will be about addiction and trauma, and then the last one will be about grief and trauma. So we have a focus every webinar, but you're always free to ask your questions and to have particular requests where we can pay attention to.
And you have to sign up for every webinar. So when you go on the website for Psychologists, you see educational program for Ukraine psychologists, and then you have every week you can just sign up, and then you get a link for these webinars, and also the topic is over there.
And the last comment before we start: if you have questions, you can put the Q&A, and we will ask them during the presentation and some afterwards. We will have like 10 minutes in the end where we can discuss and talk some more questions through. So I think this is time to introduce you, Valentina. We're very happy that you're joining us. You are, amongst other things, the president of the Ukrainian Association of Cognitive Behavioral Therapy. And yeah, we are very happy that you want to open this webinar cycle for us. And some people may already know you, but I think you have an important voice in this, this bringing together of Ukrainian psychologists here in the Netherlands.
Yeah, thank you, Esther. Thank you, Wendy, for inviting me. And I see here Dunik also here. So thank you here for also making this connection happen. By the way, I see people from our current board or previous Katerina, Lena, so also I cannot not to greet you, and also people from Netherlands, from our group of psychotherapists who are already based here. So I'm here not only as a like a CBT therapist and some organizer, yeah, from Ukraine, but also I'm a person who had to leave Kiev with my kids and then move to Den Haag. And now we are trying to find opportunity how to help like people in Ukraine, and also how to help people who were replaced, who had to flee from Ukraine on other countries and in Netherlands as well. So what we are facing, and we are facing a big situations that nobody could expect in like 21st century, right? And what have I say to you when I was getting my stuff very unexpectedly to move? I just was looking at the porcelain cup that my great grandmother managed to take with her when she had to flee in Second World War from German troops. And I realized that somehow I have to, you know, to experience something like that. And I know that one of her children died in this journey, let's say, and only my grandmother survived. That's why I'm here with you. And that was really, really, you know, for me, important moment that we are like Ukrainians. We have this transgenerated trauma in our DNA, let's say. And this is how this war impacts us also, because not only the traumas that people are facing now when they see death, then when they are injured, when they just meet death of their loved ones, destroyed houses, destroyed cities, but also in their memory and all these stories that my great grandmother was telling me, getting more life. They became more real and they also triggers Ukrainians a lot. And of course, there is like well-known explanation what is trauma. Yes, when we suffer something really, really dangerous to our life or dignity, or we are a witness that something is, someone is endangered, and we call it like a big T trauma. Yes, and of course this EMDR, trauma-focused CBT, and few others scientifically based approaches are working with consequences of these big traumas, with PTSD, with acute trauma, etc. But also, millions of people are experiencing right now with like a small T, yes, small trauma. That means that they have to flee from their homes. They are like based in a foreign, sometimes really unexpected, frightening, complicated surroundings with languages they don't understand, with the rules they don't understand, with occupations that they lost there in Ukraine and they don't have something to deal with. And this small trauma is also really important issue that needs our attention as a psychotherapist, because not only PTSD should be treated, but also all these issues with adaptation, issues with stress consequences, issues with depression and anxiety that are like, in comparison with severe PTSD, could be subtle, but also they are so important to address. And with this thing, I think, but because PTSD would have like 20% of people who went through this threatening events, but issues with adaptation will multiply this 20% and make it more and more severe for also local societies that like embraced our people. So I think that's really important to keep in mind. Another thing, what we are facing already, people who are living in dorms, in these shelters, in hotels for which were made for Ukrainians, they are living in a often not usual circumstances, yes, and they face frustrations, they face this tightness, and we know from experiments with animals, tightness make people much more like animals much more aggressive, yes, and tightness when you have to to share one kitchen with equipment with 11 other rooms, that make it also a little bit dangerous for explosion in emotional kind of meaning, right? So that's the third measure, like psychosocial, and we need to also address these issues and to help Ukrainians to to live better quality life. Otherwise, it could be like this house from cards. Yes, it could, like one card is missing and it will drop down and fall apart. So that's what I was going to address these three things. One thing, it's severe PTSD and we need like a scientifically based intervention. Another thing, it's a little trauma and there we need like low intensity intervention for adaptation. And another issue is psychosocial interventions that are looking into these circumstances where people occurred. Another vulnerable part of our concern are kids. And I'm not sure about Netherlands, but in Ukraine, we always have a short shortage with kids and adolescent psychotherapists. Yes, and here it's the same, because kids as the most vulnerable human beings, they start to produce a symptom, yes, of a family structure, and they need help, they need attention. And sometimes when there is a child who suffers mentally or psychologically, all the family system needs really good attention, and we need, and we don't have these resources, because for these 3 months, like me and my colleagues are volunteering, but you know that volunteer after something amount of time will need also some psychotherapy and some reanimation, because it's very difficult to be just a volunteer, because some of my colleagues, they lost every their practice that they had in Ukraine. For example, one of members of our group is she said that her department, yes, already not existing. I'm sorry, there is a vacuum cleaner starts, and I need to, to find it. Yes.
Take your time.
Oh, yeah. So.
But I recognize your stories, Valentina, because at World Psychologists, there are also people from Ukraine ask for psychological support, and that's the little T. But also a lot of kids and youth. And we asked our group of psychologists what kind of specialization they had. So that's why we think for youth and for children, it's very important that you have a psychologist who is specified in these problems, and also not to do, because we do online normally, but for youth and for children, we really think it's important that because we have a group of 600, so it is quite easy to see, okay, that one is in The Hague or is in Arnhem, then we search for a psychologist, and then you can do easily like walking sessions. And that there is also to all the psychologists who are listening, if you needs more help in your because probably you have a lot of people who ask you for help, just know that we also can provide a lot of psychological support.
Yeah, thank you, Wendy. And that's also an issue that we were discussed, like 4 of us, and I'm happy that you are like lobbying and going into that, how to help like Ukrainian psychotherapists to help Ukrainians and to have a job, to help it as a job, not as only as a volunteering. And next Tuesday, I understood that you will talk more about that. So we are really looking forward it.
Yeah, so that's the Psych Global is really a good option for them to read the website of Psych Global. Mm-hmm. And
so probably the only one thing that I would like to, emotionally end my this opening word, that's very important to keep something that unites all of us, like unites Ukrainians, and making that also to meet the specific things with people who are here helping us. Yes, our like hosts, because you, Wendy, you, Esther, are like hosting, like virtually you are hosting us, and as local house is also hosting all Ukrainians. And what was interesting, because we were here already on Easter, and in Ukraine there is really huge and ancient tradition to color Easter eggs. Yes, and we have specific technique how to do that. And my elder son, he's 13, and he insisted that we need to do that. For do that, we need like some specific equipment. And he watched on YouTube how to make it in a home environment, how to make it from a Coca-Cola can, something like that. And we actually made this this Easter egg. And I made a lot, and I present these Easter eggs to our friends, to our colleagues, people who I met before Easter. And that's I think symbolic thing that despite the all pain, losses, challenges, we don't want us to perceive us as the victims, but we are resilient people. We are survivors, and we want to also to make this really, red color. Yes, of our embroidery. Yes, in our embroideries there is red usually and black colors a lot of, and when they are like all together, it means this, trauma integration. And trauma integration could be also surrounded with good people. And I think that your initiative, your help, your community of the 600 psychotherapists, it's something that could really heal, could make this, red color connect with black color and let us to have a better life. Thank you for that.
Thank you.
Thank you, Valentina, for your very inspiring and personal words as well. Yeah, maybe people want to respond to you. I can imagine so. But you will be here for like 15 more minutes, I think. Yeah. So if people want to respond, they can do so, or maybe later on. But yeah, I think you really spoke from your heart and really send an important message out. Thank you.
Thank you. Thank you, Esther. Thank you, Wendy. Thank you, Tim.
So, Tim, I don't see him anymore, but I think, yes. Let's introduce you as our first speaker, Tim. I said a guest in the introduction, but actually you're not a guest at all. You are the founder of Psychologists, and you are actually involved in arranging these webinars. So thank you for that, Tim. But Tim is also an experienced trauma psychologist working with Centrum 45 and has been doing research for over 15 years with a focus on e-health and the importance of social capital in emergency situations. And you wrote a recent article or paper on the current situation in Ukraine as well. So we are very happy that you want to open this webinar and do like a general introduction on mental health care with a focus on social capital. The floor is yours, Tim.
Thanks so much. Thanks for the introduction, Esther. And I will share my presentation. I had a PowerPoint, but it didn't work on my MacBook. So I'm going to do it from PDF, but it will look for you just the same, except for the moving parts, but nobody will notice except for me. So I will share the screen. My topic today will be having a holistic view on refugee mental health. I'm a trauma psychologist, as Esther said it already. I work at a National Trauma Institute, Center 45. So I have been working with refugees, with veterans, with police officers for 13 years now, doing EMDR, CBT, imagery rescripting, and all the other evidence-based trauma therapies. But tonight, really, my story is about a more holistic view on refugee mental health, and should we immediately go for the guns and go for trauma therapy or not? And really my plea tonight is to be very modest in doing trauma therapy. I've given this talk 2 years ago, actually, in the pandemic, which is also a crisis, very different crisis, of course, for the EMDR Institute of Home, EMDR organization. And my message was just the same. Don't do trauma therapy right away, because that's a natural reflex as a psychologist. But I will empirically talk about this based on 15 years of papers. I've been doing research with Harvard University, among others, and Utrecht University. And I will talk all about this tonight, about an empirical basis for my argument, don't do trauma therapy right away. Have a holistic view. So refugee mental health, do we need to go for immediate individual trauma interventions? Well, I already gave the answer, so it's kind of a spoiler, but sometimes it really feels like the little boy on the picture, that you're fighting a big dragon as a trauma therapist, because there's so many people fleeing Ukraine, or refugees, as we could call it, and should we give them all trauma therapy? That's a relevant question. Now, my answer is we shouldn't, because there are 4 problems. The first problem, when you dive into refugee mental health, is that really, if you look into it, then you have in between 10 to 90% of the people reporting mental health complaints based on questionnaires, and that is an important thing to add. So if you would give Ukrainian refugees questionnaires, then 10 to 90%, 90, which is really a lot, will have mental health complaints. Now, should we give them all therapy? Given the fact that there are 6 million refugees outside of Ukraine, that would give us a lot of therapy to do, right? If there would be 90, or even if it would be 10%, it would still will still be way too much for us to handle as trauma therapists. Now, that is not an argument not to do it, but the problem is way too big to even handle it, if you think of it. And it's not very cost effective as well if we would do it on an individual basis. Now, another argument is, and that is actually much more important, is that forced interventions such as psychological debriefing have a contrary effect on mental health. So if you force people into therapy to talk about their trauma, you destroy the natural tendency for resilience, because not everybody who experiences trauma will have, for example, post-traumatic stress. And you will push people into post-traumatic stress. So it's actually the opposite effect of what you want to have. So the psychological debriefing, this has been proven for years, it has sometimes the opposite effect of what we want. So despite our good efforts, you might have the opposite effect. And of course, we don't want that. Now, that is a very big problem, of course, the second one. The third one is that if we look into the problem, now this looks like a difficult figure, and I will explain it to you, but if we look into refugee mental health, then we use questionnaires, right? So we use questionnaires to see if somebody's anxious or somebody's depressed. So in this figure, you see anxiety, 10 questions, 15 questions for depression. And the idea about this, behind this, is that these 10 questions of anxiety refer to anxiety, right? Because otherwise we wouldn't do the questionnaire. Now, we did research in India among refugees of natural disasters, and we gave them these questionnaires. We gave it to a group who experienced a disaster and a group who did not experience a disaster. Now, for the statistical people in the audience, or for the non-statistical people, so you would expect the most of the variance to be on the individual level related to anxiety in this example. And that was not the case at all. Most of the variance was at the community level. And that means that most of the explanation for this anxiety and this depression was the natural disaster and what happened in the community. So it's not an individual pathology, anxiety in this case, in the disaster, but it's a community phenomenon that explains the individual manifestation of anxiety. And that is super important because that means that we don't need individual interventions. So this very simple questionnaire already gave us insight that like half of it was individually oriented and half of it was community oriented. And that is really what Valentina has also been talking about. You should focus on the individual, but there's also a huge context in which we intervene. For example, Ukrainian refugees don't have shelter or tight shelter, or they don't have work where they in the Netherlands. And what do you do about that? Big part community, big part individual. Esther, you have a question?
Yeah, just checking if I understand it right. So you're saying that the individual problems, they are there because of changes in the on community level.
Exactly. Yeah. So you have an individual problem, and if you would give a questionnaire, then you think, oh, that's an individual problem. But the individual problem exists for a big part because there's a community problem. Yeah. And then should you do individual intervention? Yeah, of course not. Right? If it's a community problem. Now this is super important because like half of the variance statistically, or half of it, is explained by community level. What Valentina was referring to. And now you have a fourth problem as well, because individual, and apologies for the Dutch, I changed it in my PowerPoint, but I'll explain it. If you have individual trauma interventions, they ignore the individual resilience, and that's super important. So here's a British Journal of Psychiatry, and you see people, different trajectories of people recovering from traumas. Now the line below is easy, right? They don't have any problems. The upper line has some problems, so may need help. And then you have the line that has a dip. And that is natural resilience. So they have nightmares maybe in the beginning after 24 months, but after some years, they don't experience anything anymore. I'm not saying that you shouldn't intervene in between 24 months, but the idea is simple, that a lot of people have natural resilience and they recover from complaints themselves. So should we go in there as a psychologist and already intervene? Some people say yes. I say maybe sometimes with modesty. So again, so there are 4 problems. The number of refugees is way too big, and you have forced interventions that have opposite effect. We don't want that at all. You have a lot of the mental health problems are explained at a community level, like Valentina was already saying, and there's natural resilience, which you don't want to go by either, which you don't want to ignore either. So these are 4 problems if we go in as a psychologist. Yeah.
And Valentina is also talking about the T, the big T and the small T. Is that also a difference between those traumas?
Yeah, I wouldn't call it like that, honestly, because then a small T would even imply a trauma. But yeah, you could call it a trauma. But yeah, it does refer to that, and it goes into this, what Valentina was saying, and your question, Wendy. So the argument is that a collective crisis, such as the war in Ukraine, influences the individual as well as the community. And therefore, it should be addressed on the individual and the community level. So that you could say is a big T and a small t, but that even a big T and small t would be pathologizing, I think, and it's not pathology what we're talking about. Yeah. So it's a very different definition from trauma. It's collective trauma and not individual trauma, and therefore should be addressed as such. And that is the main argument. And this is easy to see, right? Because in the top picture, you see this woman having an individual trauma, maybe fleeing their home, or maybe somebody, or maybe she had actual trauma. And in the, so that's individual trauma, right? Symbolizing individual trauma. And the picture beneath is people sheltering in Kharkiv in the metro station, right? So they left their homes, they left their community, and they form a new community in the metro station temporarily of Kharkiv. So it's not only individual problem, but also social problem, as we all know. But it comes down to a question like this: should we, as trauma therapists, decrease the emotional memory of the collective crisis, or should we strengthen the social communities to help themselves in times of crisis? Or maybe both. Now, So I already told you, and I'm going to address it from empirical data because I don't want to talk just from my experience. I want to share the evidence for it. So I'm first going to share the evidence for collective trauma, how you can see that in an individual and a community level way. We published a paper in 2012 studying a natural disaster in England, and you could say that's different, but it's in abstract form. It's similar to war-related traumas. And what we found is that on an individual model, and apologies again for Dutch, which I changed in the PowerPoint, but in the individual model, you have resilience like this, and any CBT psychologists would recognize this. So you have a collective trauma or trauma, which leads to emotional appraisal, so to a memory. And then as an individual, you deal with it, you cope with it. So you have your coping effort, you rely on your social support. And really the constellation of these three, this emotional appraisal or this memory and this coping and social support, leads to eventually post-traumatic stress or not. And these three elements are really the elements that we work with in CBT, right? So we work with emotional appraisal. EMDR, for example, does that. Coping effort and social support is more general CBT. And then we want to prevent people to have post-traumatic stress, or we want to diminish post-traumatic stress. So this is the individual level. This is what we found in our study as well. So nothing new here, but just to lay the basis. And then I hope you see this. And then we added the community level. And the community level, what we're talking about is social capital. Social capital really is if you're embedded in a community, if you're part of social structures, right? If you're tied to social structures such as a church, for example, or if you play football, and then you can rely on those people who you know in a community. Whether you can rely on these people depends on your perception of these people. And that's the cognitive social capital. If you trust these people. So if you trust the people where you go to church or go to football, for example, whether you think these people are effective in dealing with your problems is collective efficacy. So whether you can rely on a group to deal with your problems, for example, on PsychGlobal to deal, if you tell PsychGlobal you have mental health problems, you expect them to deal with them, you attribute collective efficacy to PsychGlobal, right? So whether the collective is effective. Now, these are important. So social capital, the organizations you're a member of, cognitive social capital, trust you have in these organizations, and whether these are collectively effective. And these are super important variables in a community level. If you add all of these variables, what you see is a changed individual model. What you see is that this relationship between emotional appraisal and post-traumatic stress is gone. Now that is super important because there's no line anymore. So there's no relationship between emotional appraisal, your memory, and post-traumatic stress. And that is amazing, really. And it can be underestimated because if you are in a social group that has a lot of social connections, and you can trust these people and you can trust the collective to deal with your problems, you're not going to develop post-traumatic stress. So you don't need a CBT or trauma therapist. And that is a super important finding. Esther?
Is it important that this social capital, the social group you're part of, that this group is stable as well, or is going through the same trauma, or not?
Yep.
What are the demands of this?
So you have good social capital and bad social capital, just like you have good and bad economic capital, right? So you can use money for bad and for good. And social capital is pretty much the same. So if you have social capital which you perceive as trustworthy and which you can rely on, which you can share your emotions with, then that's good social capital. Right? So you have Ukrainian refugees here where you can rely on, or the Dutch community, for example, where you can rely on, that's good social capital. So if this is a good thing, a fruitful thing, which you can trust, then takes away the relationship between your memory and post-traumatic stress. And so, and again, this is super important because up till then, we always thought post-traumatic stress was individual pathology, but this shows that it's not individual, but it's related to the context. Whether you're in a fruitful social context really matters, whether you need a psychologist or not. Problems, you don't need to rely on your husband to deal with it because you already have the group to do so. It means that you're much more parsimonious, so much more efficient in your individual resources. So you don't need to apply your husband to do the job for you, or yourself, and you don't need to deal with it as much as you need to when you're not in a good social group. So all of this makes it much more efficient and really takes away the relationship between emotional appraisal and post-traumatic stress. So the significance of this figure cannot be underestimated, because it means that the collective, the blue part, has the same function as a psychologist, right? Because it's a preventive psychologist at the community level.
And since you're really trying to make clear how important this is, one more question about it, if I understand it right. The social support and the social capital, the difference is that social support is like a smaller group, and social capital is
that's a very good question. So social capital at an individual level, or social support at an individual level is more whether you rely on your direct friends and husband maybe, or wife. And social capital is really what exists in the community, whether I can go to my neighbors, whether I can rely on my church group. So it's much broader contextual. Yeah. But the finding is very important, because this already gives you the clue that we don't need to intervene immediately. And really, when you ask any psychologist, or most of psychologists, we want to intervene right away. Then we go to the multi-level interventions. So what we see really here in the same model again is that we go from modesty to individual interventions to strengthening communities, right? So this really is an argument to strengthen communities rather than to go right away to jump for the gun to do individual interventions. Now, we've come a long way in this, but still for sure not far enough in research. There was a Delphi study. Delphi study is nothing more that there's not enough research been done yet. So they put together all the experts around the world, and they say, hey, what should we do after disasters or war? How should we do these mental health interventions? And this Delphi study, 2007, back then, so this, I'm going back a bit, they say, so don't go to mental health interventions right away, but try to make refugees feel safe, calm refugees, so normalize it in refugee camps and give them back their normal life and function, or in the host community, of course, like in the Netherlands. Strengthen collective efficacy, so this is important, this collective efficacy. So try to make groups deal with the problems in a collective fashion. Create connectedness, so this is really the social capital, and create hope, so give them tools, refugees, for problem solving. So these are the 5 elements which really come down to social capital and collective efficacy, if you could translate it into these terms. But it's still very vague. So 15 years ago, this was super vague. There's a Delphi study, not much has been done before that. Now, in 2014, we published a paper from Rwanda. You probably know, but I'm still going to say it. In Rwanda, there was a genocide, of course, in '94 between the Hutus and the Tutsis. So the whole communities have been disrupted. So social capital, as we talk about, has been disrupted hugely, right? If you have had these Hutus and Tutsis killing each other. There's nothing left of social capital anymore in between these communities. So what colleagues of mine did is go to Rwanda for a while, and they did these community interventions. So going into what are these community interventions, and what they did is they did a 10-week program of social therapy, called social therapy. And what they did, so they went to these villages in groups of 10 people, and they could discuss any topic they want. How to get work or how to get by, but it couldn't be trauma related. So it couldn't be psychotherapy. So it really had to be social therapy, so general topics. People sat together for an hour, 10 weeks, and that was the only thing really they did, Hutus, Tutsis in their villages. What we saw, and this may seem difficult, but I'll explain it to you. So what we saw is that this social therapy, even of 10 sessions, improved social capital in terms of civic participation. So you see that in the top over time, like really. So after 3 months and after 9 months, we saw that the civic participation changed, only due to 10 sessions. So this getting together changed the civic participation, whether you participate in your community or your village. It also changed mental health, whether we didn't talk about mental health. So it improved mental health, it improved civic participation, but it wasn't related to each other. So we tried to relate it to each other, civic participation, mental health. We couldn't find a connection in between, but it did improve social capital, civic participation, and mental health. So it improved depression and anxiety. Yeah, so this was really the first quantitative research on community intervention and how you could do it in a very difficult community such as Rwanda. Then we dived into literature. And then we thought, okay, so what is there up till now? So we did systematic reviews, one on social capital interventions in public health in general, and the other one tailored to refugees, really. And what we what we found is that there are several studies, not much. We only found 17 studies to be exact, really. 17 really, after like 3 decades of social capital research, is really nothing. And what we see is that these social capital interventions are really vary. It can be anything, right? So that makes it really difficult. One really nice study of a community intervention was by Brun and Bossert in 2009. They went to Nicaragua and they applied, they promoted management and leadership development of community leaders. And they saw that these community leaders were more effective in leading their communities, managing their communities, and that really made a difference for people. So what it did for people is that they could address problems more effectively. It improved trust of the individuals in their community, and it improved health behavior of people. It improved relying on the health systems which they lived in. So this leadership and management development of the community leaders really trickled down to individual health behaviors and health outcomes. So this is a qualitative study, but it did make a huge difference in 2009 in Nicaragua. Now, the argument really, what I want to say is that you should go for multi-level interventions, and I'll be more clear on that in the end. But multi-level interventions is that you address the community and the individual. Now, there's a couple of 3 studies on that. We only found 3 studies. I think there's still not more on this. So I think, yeah, the research should do more research on multi-level interventions. 3 studies. One in Spain. It connected health centers in Spain together, and it focused on older people in need. By connecting all of these health centers, it let people participate more in the community. It decreased the loneliness of older people, and therefore it improved depression outcomes. And also, what it did by connecting all of these people, it could distill people in need for psychological interventions. So in Spain, it had a community intervention, so it did community. It brought the people together in a community in Spain, but it also distilled people in need for psychological interventions for whom there was still not enough. So this is a really nice study which shows you how to combine community interventions and individual interventions.
This example is not after a war or
not after war, but it's a general principle of multi-level interventions. Yeah, but the same applies to war, and I will get to that in a second. So you started a community and you distill people in need, and that is really the sequence which we should have. There are other research, other papers. Anderson et al. They did physical exercise. It goes to show that really social capital can be anything, but when you bring people together. So they did physical exercise at work and individual physical exercise, and it improved health outcomes. Yeah, for sure. So it improved social capital and health outcomes. And the last one is for Dutch colleagues. They included a dialogue in the organizational level. This is not war either, and at the individual level, and it improved health outcomes. So just kind of like Rwanda, it improved the dialogue in the organization and in the individual level, and it improved health outcomes. So these are really the only three papers on multi-level interventions, whereas most of the researchers say we should do multi-level interventions. Yeah, I'll come back to that. Sometimes community interventions are more symbolic. So community interventions are more symbolic, like, and this makes it broader, but I really think this is also a community intervention. When President Zelensky spoke to the people in the first week of Ukraine and told everybody in front and right downtown Kiev, we're all here. We're all here. The president is here. The presidential staff is here. My ministers are here. And this can be really a community intervention of giving people hope. So sometimes it's not only of bringing people physically together, but really giving hope to people. And I think this is also a community intervention that has a trickle-down effect on mental health of people. And the other one, really everybody knows, is this community is not a community intervention, but of Snake Island, where Ukrainian soldiers were beleaguered by a Russian warship, and they told them to go fuck themselves to the warship. And there was really a symbol of resistance, or still is a symbol of resistance for Ukraine. And that is also a community intervention in between brackets, which has a trickle-down effect on mental health.
Now, and was it also when Zelensky said after the European Song Festival, so next year we will be in Mariupol?
Yeah, exactly. No, exactly. And this makes it very abstract, but I really think this is also part of community intervention. So we should have a much broader look on refugee mental health. And this, I mean, Zelensky is really, for me, a hero, the way he addresses this, because this really gives people hope. And I think it has, in my empirical model, it can have a huge effect for mental health of refugees. But going back to the reality and the tangible reality, then what should you do as a therapist? Conclusions, which are important. So the interventions on the individual and the community level are linked to one another. So the individual and community level interventions both work via the same CBT principles. So whether you live in a good social community that addresses your problems really makes all the difference. So in that way, social capital, good social capital, fruitful social capital, functions as a collective therapist for the community. Just like in the example, like Zelensky could function as a collective therapist to bring people together. And by starting to strengthen social capital interventions, people can distill individuals in need for individual mental health care. Now, what should you do? We've been, me and my colleagues from the US, from Harvard and from Boston University, we wrote a editorial paper. And so first, our idea is to start by building social capital, really. Wherever refugees are in the Netherlands or in refugee camps, or you should really provide social spaces, open spaces, where people can get together to build social capital among themselves. Now, this may seem very simple, but this is really key if you think about it in this model. So wherever people can get together and deal with problems or talk to each other in a community way, this builds social capital and can have a preventive buffer effect for mental health problems.
So is it also possible to have sport? It doesn't matter if you are at park, cafe, or sport. And what about age? Does it matter if you have the same age, or can you have also mixed with children and adults?
Yeah, so the idea really is that you should build a community, right? So where people get together in a host country like the Netherlands or a refugee camp in extreme circumstances, you build a community again where you normalize the circumstance, so where people have functions again. So if you're a psychologist, maybe you want to work as a psychologist in the Netherlands, hopefully, and so you bring people together. You let children play again, and you let other people take care of the children again, just like you would do in Ukraine. So you form a new community with social capital. So one of the first things you should do is create spaces to form this social capital in a normal way. Now, the other one is that to ensure accessible telecommunications to have contact with family, of course. That is also a form of social capital, of your social capital back home or in other countries. Then is perhaps to organize informal events, religious celebration, religious activities, to facilitate them or to organize them. Communal cooking, you could think of. Yeah, and so physical activities, virtual spaces, activities, all of these can be part of social capital. And at fifth, you can bring refugees together with the Ukrainian diaspora, which already lives in the Netherlands or other countries. Yeah, so this is really where you start. So these are 5 guidelines of where you could start to build social capital in the host country, and this is where you start in multi-level interventions. But it's multi-level interventions. So how do you see that? So this is the a multi-level model, but then in a public mental health pyramid. Maybe some of you know this already. So the top pyramid is a public mental health pyramid. It's kind of like the Maslow pyramids of needs, but so you start with the community and the family support, and this is where you do social capital interventions, like what I described on the previous slide. This is where you start, and then you distill people in need. So this is the second one. So in these community interventions, in these community spaces, you try to see if there is actual people still in need for that have severe post-traumatic stress, that have severe psychotic symptoms or severe depression. And this is really the people where you give help to as a therapist. So not everybody, of course not, but you distill the people in need within community interventions, within communal spaces. So you start here and then you go there. And this makes a lot of sense, because then you really are much more efficient with your resources. And that is actually the same as we explained in our model. So you started a community, so you build social capital and collective efficacy, and then you're the actual CBT therapist for these refugees in this.
And there is one question, Tim. from Marion Peters, and she asked if there is a difference between natural disasters like hurricane, or floods, or tornado, or in right now we compare with the war in Ukraine.
Yeah, there is a difference, of course, because you have much more interpersonal traumas. So you would expect much more actual post-traumatic stress, higher numbers of post-traumatic stress, higher numbers of pathology. So what we know is that sexual traumas and killing of people have much more severe effect on mental health. So lead to pathology much more easily. But the model is still the same. So the social capital is disrupted because you live in another country. You lose your original social capital in your village or city. And so you start at a community level and you distill people in need. So in wartime, you expect more people in need that have post-traumatic stress symptoms, because these traumas, big T, as Valentina called it, are much more severe and much more related to severe mental health problems. Yeah. So the model is the same.
This building new social capital. So if you go live in another country and you have to build like new social group, and you, for example, for children, they have to go to school, but if it's all temporarily, if you're thinking about going back again, isn't it like traumatic again, maybe? Or I can imagine that it's hard to attach to this temporarily place and building a temporary social capital. How do you think about that?
Yeah, this is a very good question. So of course you should base it on you should think about this very carefully. But as for now, unfortunately, it seems like a protracted war, right, in Ukraine. So, and if it's a protracted war, then it makes much more sense to really normalize life in the host country for children and for their family. So, if it's just a temporary thing, which we all hope for, then you wouldn't do all of this, of course. But yeah, if it lasts longer, then you should really build social capital for sure. But even really, if it takes a couple of months, then it's nicer for people to really feel at home in a community, of course. Yeah. All right.
Yeah, there is also Gea Dunnick from World Psychologists. She also went to Lesbos with the Camp Moria, and she also noticed that in that refugee camp there was a lot of social capital, because there was a barber shop, a tattoo shop, or a grocery, and there was not that much post-traumatic stress syndrome, because they built up their own social capital.
How cool is that, right, Wendy? Because that is exactly the point of this model. And so really, if you listen to the story, you could say like, okay, so this makes a lot of sense. But really, when you ask psychologists what should you do, then they would say, okay, give therapy. And if you go to Lesbos, when you go to these NGOs in Lesbos, if you ask them what to do, they say, yeah, community interventions. So, and these are really two estranged paradigms, right? And so how can you connect them together in this same model? So for years, people have been doing community intervention without therapy, and therapists say, okay, I'll just go there and give therapy. But the truth is a combination into a multi-level intervention. Yeah.
So a question from Maria: how can we inform and convince Dutch people that host Ukrainian refugees that social capital interventions are needed first before people are referred for individual mental health care? This seems not always so easy, is what she's saying. Do you have recommendations?
Yeah, I think that is so. This is a very good question. This goes to awareness, and so this is really teaching the host community what is public mental health in a broader perspective. So I don't have an answer to that, but I guess there are many ways of doing that, like telling the story today, or telling it to a broader public in another form. But I like the question because it really underlines that is very difficult if you have refugees in your home and then you think, okay, so they need to go to a psychologist, but that's not necessarily true. So I think it's a big message that we should tell people, but I'm not sure how to convey the message. I think everybody should hear this more broader vision on mental health. And which is also really nicely underscored by your story, Wendy, in Lesbos.
Yeah, and I can also imagine when all the psychologists from World Psychologists have a match with refugee people, they also can have talk to how can you join more social capital activities, so we can just motivate them to search if there is anything nearby, or sport or school.
Yeah, exactly. And that is really what you should do, because otherwise we make all of these refugees patients, which is really ridiculous to do. And also we don't have the resources to give therapy to everybody. So we pathologize a normal reaction, really, and which is it's paternalizing, really. It's belittling because it's a normal reaction if you come from war, that you have mental health complaints, which are very normal and which dissipate for a big deal. Yeah.
But Tim, as a psychologist, if people are referred to me, for example, I feel like I want to help them with my experience, with my studies, and I don't want to just chat. And it seems so simple, and it seems, should you really say to those people, like, you should focus on your social surroundings before going to therapy?
Yeah.
Yeah.
And unless people really have pathology, right? And unless people have nightmares, and then sometimes trauma therapy can make a big difference, of course. But in the first phase, the idea has been for years to watchful waiting, right? I'm sure you heard the term, but to wait. And so now there's been a study, because EMDR therapists, they always want to do EMDR, but so they compared it, like watchful waiting to EMDR, and it's equally effective. Yeah. Okay, so what should you do then? And so.
And how about group therapy? Because in this example of Rwanda, there was somebody guiding these gatherings, and
there was a sociotherapist. Yeah.
So is
There's a
that needed?
So group therapy has by definition is more about intrapersonal problems, right? And this is more about interpersonal problems. All right, intrapersonal. So if somebody reacts on me in group therapy, and I reflect on where it comes from in me and what is my role in the group. But social therapy is really about everyday problems. So that's a difference. Yeah. But Esther, you really verbalize the problem, right? So if you have patients like, oh, you really want to do something, but if you think of it in this model, then you should connect people to a broader social network, and which should be at least be part of your solution.
Yeah.
All right, we naturally came to questions, so.
Because we can spread the message, of course, but it's a good question. Is it also, you said it belongs to community health, or is it also the government has to do things, or where can you solve this topic?
Yeah, I think it's difficult, right? Because if we think about psychology, it's much more individual, and then you think, oh, okay, so there are 5 evidence-based trauma therapies, so I would just pick any one of them and then I'm doing good, right? But social capital is such a broad concept, and social communities are such a broad concept, so there's such a wide range of things you could do. But the general thing is that you build a community. In England, for example, after a natural disaster, they had a community center where they brought people together, and that was it. Just like our first recommendation, that was it. So people would do laundry for each other because their washing machine was broken, and people would do whatever for each other, and that really built social capital. And that is a social capital intervention, by just providing the space. But it can be anything. In Japan, they do the same for older people. They do games in a community center, and that decreases loneliness and depression. Another example from Corona times, and I know this is different, but the principle is the same, is that in Amsterdam, for example, they brought people together who could help each other, right, on a website. And that builds social capital. If people couldn't go out of their home, people would do grocery shopping for each other. That is a social capital intervention. So it's really about bringing people together and let them help themselves or talk about issues. So that is an abstract idea, but it's very effective in addressing mental health problems.
And is there still going new research? Because now we have a lot of people in Ukraine, so we have to see if we can focus on more social capital and see if it is, in research combination with research.
Yeah, I don't know of any research on the Ukrainian community. I think it would be a great topic to see if this model holds for Ukrainian refugees. I'm sure it will, but we need to prove it. But I don't know. It would be an excellent opportunity, really.
Yeah. And it's not like a cultural thing. You said it's Uganda, Japan. It's like it's not.
No, not at all. Not at all. No, because if you would think of it, then the Dutch community is a very individualistic community,
Yes.
right? And so you have the Institute for Urban Mental Health nowadays from the university, Amsterdam University, and it researches why people in the city of Amsterdam have poorer mental health than people outside of Amsterdam. And they see that it's related to poorer social capital, really. So if you would bring people together in communities, in neighborhoods in Amsterdam, it would have exactly the same effect. Yeah, so it's not a cultural thing.
Yeah. Wow, nice. Is there any question, Esther? Did you see if there is a Q&A question?
From Nina, maybe there are researches on how to build safe communities for migrants.
Yeah, so these researches or these papers I showed you, you could read our systematic review from 2018, and we have all the 17 papers in there. The papers up to date, but I'm sure there haven't been much more. And we wrote a paper on systematic review for social capital interventions on refugees. It came out last month. But I would recommend these two papers.
Yeah. And there is also a question if you can share the PowerPoint.
Yeah, of course. Yeah, no problem. Yeah.
And how can we organize that? Is that?
I will ask our management assistant to send it. Yeah.
Great.
There are some more questions now. We still have time, right? We have to.
Yep.
A question from Maxime. Is there a specific difference for helping people with trauma from psychologists which are located in the same level of stress area?
I'm not sure I understand the question.
Is there a specific difference for helping people with trauma from psychologists which are located in the same level of stress area? So from Ukrainian psychologists, I think in this case.
Yeah, I don't know if I understand the question right, but I think what Maxime refers to is that psychologists may suffer from the same problems in the same stressful area. Yeah, of course, but then you would need to think about the psychologists and the mental health of these psychologists, because it's more confronting to be confronted with traumas from Ukraine, of course. So that is for sure something to consider. And on the other hand, it's also very nice and grateful for Ukrainian psychologists to be able to help people from Ukraine. So it's a trade-off, I guess, which every psychologist from Ukraine should make for themselves. Yeah.
And one interesting question from Marta as well. Can national groups on Facebook be social capital? Yeah.
I didn't hear it.
Sorry. Can national groups on Facebook be social capital as well? like Facebook groups?
Yeah, I think so. I think it could be. Honestly, so there's been a lot of research on digital social capital. Yeah, I'm not sure if it has the same effect, honestly. I think you can have digital social capital, but we all notice even in Corona times that it doesn't have the same effect as actually getting together. So I think it can have a good effect. You know, it can, if you create a group on Facebook that can address in a collective fashion problems, so it has collective efficacy, and where you can ask questions about Holland or about Ukraine, it can have a very good effect, but I don't think it's the same as coming together face to face in terms of mental health outcomes.
So now we have the webinar to build up like this, but you can see in the point of social capital, if we see each other, all the people who are joining this webinar, will that also be a little bit more social capital?
Yeah, I think so, but I don't think I don't think it can replace social capital as coming together in a community center.
Yeah.
Really, I don't. It really can't. I think it has such a more profound effect on mental health. Also, I would assume it's a hypothesis, but what you see in these more digital social communities, that it doesn't have such a strong effect, really. Yeah.
And Tim, a question from Lydia. She worked at a refugee center, as it say, and it was always a struggle to get the residents, the asylum seekers, to get involved. So how can we motivate such people who are still adjusting to a new community and still maybe traumatized to get involved in social interventions?
Yeah, so I think the same applies, but it's easier said than done. I think the same 5 principles as we put forth in our paper, right? In my conclusion applies. So you could create a community space, or you can create activities like sports or cooking classes or cooking together. And if people aren't willing to participate, then some of these may be too traumatized or too depressed. And that is really the people you want to distill for individual therapeutic interventions. So you want to start it and then see if some of these people aren't motivated, and you have a chat with them, like, hey, what is the reason you're not joining? And if it's pathology, then you refer them to a therapist.
But a question that sticks in my mind is, when do you decide that you have to refer someone, and when do you stick to like social capital intervention first? When is there like a certain time when you have to check how severe it is, or do you do diagnostics, or do you?
Yeah, well, so for children, they say within 4 to 6 weeks you intervene, right? So that's because the longer you wait, the harsher these problems are. And for grown-ups, that they say, yeah, well, at least a month, of course, but mostly longer, because then you still have resilience of people. So children, you go faster than grown-ups, but if it's really invalidating, so if you, yeah, and we can all picture that, if it's really invalidating for a refugee that has such nightmares as I say, in asylum seekers center, then yeah, for sure, then you want to go straight to therapy, but that's not for everybody.
Yeah, because I was shocked by one of your first slides that it can work contrary if you force people to do like trauma therapy.
Yeah. So and that is not for the people who are really invalidated, right? So that's for people. If any of us would experience war, we would probably have nightmares and or be sad, and if you force these people which can still function into therapy, then it can have a contrary effect for sure. Yeah.
And there is also a tip, the documentary, The Swedish Theory of Love. It's all about the social capital, loneliness, and mental problems. I don't know if you know the documentary.
I don't know it, but
okay.
Thanks for the tip. Yeah. Yeah.
The Swedish Theory of Love. Yeah.
I also put a link in the chat when you can sign up for the next webinars. There was also a question, and I think we miss one question? I'm not sure. So
I don't think so.
I don't think so.
No.
Well, is there any open end? Is there no, something left? Is the message? Yeah, I think it's quite clear, Tim, what you were talked about, and for me it was very new that it was that important, and it makes me refresh again that it's of course, you know, it's of course logical. Then you need that social capital, but now it's really in my mind that we have to address these.
Yeah. No, thanks for saying that, Wendy. And really, the only thing, but which is really important, is the thing we did is provide the evidence for it. You know, so yeah, all of these papers really provided evidence for this that we should really address this social context. Yeah.
Yeah, and the impact of it, because you would say, of course, it's important, but that it has such an importance.
Yeah.
That's really good to stress out. And I think this is a very good beginning of this webinar series. So that first step, you have to watch carefully if it's needed to do like further therapy, where the other session will be more about. So this is a very good beginning. And thank you so much, Tim, for sharing your knowledge about this with us.
Sure, thanks so much.
Yes, and if you have any recommendation to us or any questions, please sign up on LinkedIn. Esther also put the LinkedIn of Psychflix or my name or the Psych Global or World Psychologists. So on LinkedIn, we really want to have any reaction, and that will help us.
So what you can do, Esther put it only to us, but I reposted it in the chat. So please let us know what you think of this first webinar, if you liked it or not, and just let us know. Send a comment on LinkedIn, and we want to know. We want to hear your feedback.